From hyperthyroidism, we go to hypothyroidism now, and we want to talk first about the etiology. And of course, about 95% or even more actually of all the cases of hypothyroidism are primary. It's an organ failure of the thyroid, primary organ failure, and less than 5% of the cases are due to the pituitary, and even a smaller number of these are due to the hypothalamic causes, suprathyroid. So basically 95-97% of all the cases of hypothyroidism is something wrong with the gland itself. If you're talking about medical disease, if you're talking about a disease state that causes hypothyroidism, the most common form that we see in this country is chronic thyroiditis or Hashimoto's thyroiditis. So if they ask you what is the most common cause as a disease, what is the most common disease that causes hypothyroidism, it's Hashimoto's thyroiditis. In this country, we also see another form of hypothyroidism because of the way that we treat hyperthyroidism, toxic nodular goiter, and Graves' disease. One of the most common etiologies of hypothyroidism is post-ablative radioactive iodine ablation that we do in patients to treat Graves' disease and other forms of hyperthyroidism. So right here, the first two cases here, the first two scenarios, chronic thyroiditis and post-ablative, not so much surgery, but radioactive iodine, basically account for about over 90% of the cases that we see in this country of the primary, which are over 95% of all the cases. Then we see some other stuff that are less likely, like drugs. Lithium is a very common cause of hypothyroidism. Amiodarone is another drug that we have to think about. And then even rarer stuff like biosynthetic defects in children, where you have enzymatic deficiencies, or in rare places where there's iodine deficiency, rare parts of the world where there's iodine deficiency. This is very uncommon now because all the salt and all that is saturated with iodine, and basically that we've done away with that. But basically, the most common forms that we see is Hashimoto's thyroiditis and post-ablative radioactive iodine in this country. So what do these patients present with? Well, the classic presentations is cold intolerance, constipation. Some of these patients develop carpal tunnel syndrome. You have to think about this. I told you in acromegaly that when the patient presents with bilateral carpal tunnel syndrome, you have to think about hypothyroidism. You have to think about acromegaly. One of the symptoms that they test us about is pseudodementia. Now, pseudodementia, not real dementia, but they present just like Alzheimer's disease, where the family is complaining that this guy is, not paying the bills, is forgetting things and stuff like that, pseudodementia. And when you see the neurologist evaluate patients for Alzheimer's disease and so forth, one of the first evaluations that they do is they exclude pseudodementia or reversible dementia. They call it reversible dementia, but it's really pseudodementia. And the two things they always exclude is hypothyroidism and B12 deficiency. You have to exclude those before you make the diagnosis of a dementia syndrome like Alzheimer's disease, like Pick's disease, and so forth. So please look for that. Please exclude that. Please exclude thyroid disease as a cause of pseudodementia. They have increased weight, they have dry hair and skin, they may develop a hoarse voice, and now they tell us a couple of other things that they test on the boards. One of the things that they tell us on the exam is that they develop slow, deep tendon reflexes. Now, when you tap on the reflexes, on the knee reflex, right, and the ankle reflex, the upgoing part is normal, right? So the reflex goes up like that normally, and it's the relaxation phase, of the deep tendon reflex that's delayed, that makes you think about the diagnosis. So the slow, deep tendon reflexes is not the whole reflex, but the relaxation phase of the deep tendon reflex that's most consistent with this. Then they tell us also about this last thing about an elevated cholesterol. Now, a lot of people in this country have elevated cholesterol, so it's not a big thing to find elevated cholesterol in people, especially if they're older patients. But this patient, they tell you about a patient that had normal cholesterol up until this time. She's about 65 years old, and all of a sudden now her cholesterol levels, for no reason at all, start to creep up. And one of the things you have to think about is hypothyroidism, making that cholesterol go up, and you have to test for that. So all these symptoms are important, but I want you to pay attention to the bilateral carpal tunnel syndrome. I want you to pay real attention to the dementia, pseudodementia, and please remember the deep tendon relaxation phase, the relaxation phase, and the elevated cholesterol, and think about hypothyroidism. So how do we make the diagnosis? It's very easy. We check a combination of T4, free T4 of course, right? We don't need the T3 that much, and TSH, because 95% of the cases are primary hypothyroidism. We'll get this right here, a free T4 that's decreased, right, and a TSH that's very elevated. That's the typical patient with primary hypothyroidism. That's the most common scenario that we see. And then only in rare cases do we see the other form, right, where it's pituitary, so the free T4 is low, and now the TSH is also low at the same time. Now here in your table, we put this for purpose. TSH could sometimes be normal in secondary hypothyroidism. It could be normal, but it's normal. It's normal, meaning the levels of it is within normal range, but it's abnormally low with the consistent low 4T4. Remember, when you have a low 4T4, your TSH should always be elevated. So this patient has abnormally normal TSH depending on the low free T4. Now, the other thing that I like that we've put in here for you is that usually patients with suprathyroid, pituitary, or hypothalamic related hypothyroidism, they usually have other related hormone deficiencies. It's very rare to see only isolated TSH deficiency. Very rare, almost unheard of. So what are the things you're going to see? You're going to see growth hormone low. You're going to see FSH and LH to be low, the gonadotropins are low, and sometimes even ACTH is low. Remember, these are all the hormones in the anterior pituitary, and if one is affected, the other ones are affected, and the ones that are affected most likely are the gonadotropins and the GH, and then it's TSH. So you should see abnormalities in those hormones always. People with primary hypothyroidism, there's nothing else going on, right? It's only the free T4 that's decreased here, nothing else. So that's what I want you to remember. So how do we manage these patients? Well, it's very simple. Most people, once they make the diagnosis, they don't do much more. They don't do much more because whether it's Hashimoto's thyroiditis or some other form of hypothyroidism, nobody really cares. What we really do is we treat the patient after we make the diagnosis. So let me say this again. Most of the cases of hypothyroidism, because it doesn't change what you do for this patient, we really don't do more testing other than document hypothyroidism, and then we say, okay, it's likely to be Hashimoto's thyroiditis or some other form of chronic thyroiditis, but it doesn't matter because it doesn't change my management here. What do I have to do? I have to treat hypothyroidism, end of story. How do we treat this? Well, we give them what the main secretory product of the thyroid is. What's the main secretory product? It's T4, so we give them back T4. How long? Lifelong, forever.